Lovely. So, my name is Maureen Tilford. I'm a former GP in the UK, and I'm a trustee of the BSCAH, the British Society for Clinical and Academic Hypnosis. And today, very excited to be interviewing Dr. Mark Jensen, who is in Seattle, so he's thousands of miles away, but here we are, chatting like we're next door. Now, Mark is a professor and vice chair for research at the Department for Rehabilitation Medicine, University of Washington in Seattle. And for many years, Dr. Jensen's been doing research into how we understand pain, the scientific understanding of pain, and the most effective methods of dealing and managing pain. So it's all pretty straightforward there, but I'm sure quite complicated in the actual doing of it. Anyway, you've been at the forefront of research and developing the efficacy of patient-controlled pain management. I think that was something you like to have. Patients are in the driving seat pretty much, not dependent on a godlike figure of the doctor. And you've looked at cognitive therapy, activity management, mindfulness, and hypnosis. So today we're kind of interested in hypnosis because that's our bag at the BSCAH. And of course, it's got a huge body of evidence regarding pain and hypnosis. So looking today at the role of hypnosis for pain, when I mention it to other colleagues, they often say, well, there's no evidence for any of that. It's all a bit woo-woo, But obviously, there's a huge amount of evidence going back many years. So what do you say when they say that? Is there a quick response to that? Or is it take half an hour or...
Well, I would just say, as it turns out, there are many clinical trials, and there are a large number of systematic reviews of those trials that conclude that hypnosis is effective for pain management. So there is, but I understand people say there's no evidence for X because the literature, the medical literature is huge. So unless you look for something,
right,
you won't find it. But if they were to look for it, did a search, they'd find it.
There it is.
So there's evidence. It's effective. Yeah.
All right. So
it's pretty straightforward.
Right. So you can just rebuff that theory. The other thing that you get from colleagues and from some other people who don't really know much about hypnosis, they're a bit fearful of it. It's all a bit weird, and they've seen things on the TV, and they just think they find it suspicious and a bit strange, and not really to do with clinical care, or that a doctor or a therapist would even think of it. So I mean, it's got a lot of baggage, a lot of funny history. I mean, is there a way around that? I think in your, when you were telling me things that might be interesting to mention, you would say, what would you say about seeing it on TV or theatrical performances? I mean, do you have a
Yeah, well, so I think the majority of people have concerns about hypnosis because the way people mostly learn about hypnosis is through movies and stage hypnosis.
Yeah.
And what I say is that what you see in movies and what you see on the stage is not clinical hypnosis.
Yeah.
That's entertainment.
Yes.
And most often what you see in movies is not possible. That it just doesn't happen. So you can just say it's a weird plot device. Human beings, we have a great deal of concern over control, self-management, who's in control of my life. And so hypnosis is a great plot device to get at that issue. But what you see on in movies is not real. It's made up.
Somebody made it up. Yeah.
Yep. And that's hypnosis to entertain people. And on the stage, it's entertainers who are manipulating audience members to have them do stuff would be viewed as embarrassing. And they don't use hypnosis. Certainly, they use a lot of strategies. But so I make the distinction between clinical hypnosis and entertainment hypnosis.
Yeah.
And people won't learn about clinical hypnosis unless they try it, because it's not shown in movies or on stage. And clinical hypnosis is about giving people more control over their symptoms and their experience. It's teaching them how to use their brain's capability of making rapid changes to make certain behaviors automatic, like the right choices for foods or the right choices with respect to cigarettes, or
Yeah.
feeling more hopeful or feeling more calm or feeling more comfort.
Yeah.
And it can be very powerful. That evidence, as we talked about, shows that it's effective. So why not give it a go?
Yeah.
That's what
Yeah.
I say.
Got nothing to
And
lose
patients,
here. Yeah. I
when
was
I
a bit,
explain that to patients, they usually say, okay, I'll give it a
yeah,
go.
go for it. Yeah, you've got a really good spiel there. That sounds brilliant. But I was a bit sad. I watched a tiny bit of the Jungle Book the other day for some bizarre reason, and they've got the blooming snake hypnotizes Mowgli. I mean, and his eyes are revolving, and Mowgli's going, you know, I thought that's really bad. You're putting it into the mind of the child really early on in their development to make it
It
look real.
starts very early.
Yeah,
Yeah, I can remember as a child seeing this on TV, and so it makes complete sense that people will be skeptical and they'll say that can't be possible, and they're right. What you see
yeah,
on TV is not possible.
yeah, yeah. And they're highly selected. The people who get up on the stage and behave like chickens are not. They're exhibitionists and also highly suggestible. So a very tiny
That's right.
select group. Okay,
Yeah, they
so
very
that's
much are, and the stage entertainers know how to pick them,
oh yeah, they
and
spend
they'll
hours.
whisper under their breath, let's give them a good show.
Yeah, yeah,
So
they make money.
it's that is not clinical hypnosis where you teach somebody skills to make their life better.
Yeah, entirely different. Quite the opposite, really. Okay, so we have to explain to people what it isn't and clarify that. But therapeutic hypnosis for pain has been shown to be very effective. And I think you mentioned that there are other, apart from easing the pain, it has a number of other positive spin-offs. So what sort of things are you referring to there?
Yeah. So I've done a number of clinical trials, and in one of those trials, we called patients and we were curious what were the side effects of hypnosis. We were actually looking mostly for what negative side effects they were, because that hadn't been studied.
Yeah.
And three negative side effects were mentioned. One person said, it wasn't as effective as I hoped it would be. One person said effects didn't last as long as I hoped they would.
Okay.
And the third person said, what did the third person say? Wasn't as effective. Um, I don't remember, but it was also
Yeah.
similarly benign. But then they listed a whole lot of other side effects, like I'm sleeping better, I feel more control of my life, I feel more calm.
Yeah.
I now have a tool I can use to manage my pain.
Yeah.
And so hypnosis, the therapeutic hypnosis for pain, is not only effective, but it has a huge list of positive side effects. Now,
Yeah.
if you had a drug that had that efficacy and that side effect profile, it would be the first drug people would be offered. And whoever invented that drug would be a billionaire. But nobody makes money off of a treatment that empowers patients.
No, quite the reverse. They're going to
So
lose
nobody's
money.
offering this nobody's selling this, but it would be the first drug. And so I see hypnosis should be the first line of treatment that
Yeah, you
anybody with
just said
chronic pain
that.
gets.
Yeah, or even before drugs.
Absolutely. First line before anything.
Wow.
Absolutely.
And you can teach them their own
Yeah.
skills,
Yeah.
which is
Yep. Yep. Yeah.
which you can't.
Yeah. Drugs have all kinds of negative side effects, and depending on the drug, some make pain worse, make pain better in the short run,
Yeah,
make pain worse in the long run. So,
yeah, yeah.
absolutely, first line treatment.
Okay. So that's going to be a hard sell, isn't it? You're not going to get too many doctors, but maybe. I think more and more now.
Well, I think physicians are tired of offering treatments that don't work and make things worse.
Yeah.
And so if they have the option of referring patients to somebody who can empower that patient, so the patient doesn't have to come back to them, or
Yeah.
learn how to do this themselves to teach their patients. They have it's why not offer patients the thing that's shown to be most effective as empowering?
That seems
Why not?
too blooming obvious, isn't it? It's not the way we operate usually. That's not the way it works.
It's
That's not
yeah.
how we do things.
Well, I hope someday it is the way it works.
Oh yeah, well, we're inching forwards here anyway, aren't we? Anyway,
That's right. I think we are.
yeah. So these are the benefits. So of course, and it's wonderful for patient to be able to do their own self-hypnosis because it gives them agency, doesn't it? You know, instead of being the victim of the pain or the victim of the doctor or the drug, you know, suddenly they've got this other thing. And the other thing that people often say about when they're in a hypnotic state, when they're in their trance, they're completely aware of everything that's going on around them, but they don't care about it. They haven't got this critical mind diggling away. People are often surprised that they're not in some kind of coma, which is
That's
always
right.
anyway.
That's because of the movies. Yeah.
Yeah, yes, of
Yeah.
course.
One of the things one of my mentors told me is that when it comes to chronic pain, people do much better depending on what they do themselves than on what is done to them.
Yeah.
And for chronic pain management, the key is teaching people how to manage it themselves, and then they will do very well.
Yes.
If we're trying to do things to them, surgeries, medications, injections,
Mm.
massage, chiropractic care, and I mean,
Yeah,
some of these things can have short-term benefits, but the things that have the most long-term benefits are things that patients learn to do themselves.
they can do. Yeah,
Pain is about self-management, like diabetes.
sure.
It's not something that's cured or
No,
surgically removed.
no, quite. Okay. And people quite enjoy doing their own self-hypnosis too, don't they? They become quite skillful at it and quite enjoy their
I,
little
certainly a large subset do, but there's also people, I don't want to oversell it. There are people who don't like it very much,
yeah.
and that's fine. They have other options. They can learn meditation. They can learn cognitive therapy.
Mm.
So it's not a magic bullet. It's
No, no.
it's effective, but like any treatment, it's more effective for some people than for others.
Yeah, yeah, yeah.
But again, given its efficacy and given its side effect profile, I think it should be the first thing offered.
Sure. Do you think there's an element of placebo? Is the placebo a separate effect in the brain to hypnosis?
Yeah, I think there's a placebo effect for any
Any.
active treatment. Yeah,
Yes. Yeah.
and that's why in our studies we have control conditions to control for that.
All right. So you can work out if it's placebo. What, you're looking at scans?
I don't do scanning research. There are certainly others that do, and certainly placebos have different effects on patients than hypnosis, as does meditation. Each of these things has a different
Yeah.
effect.
Yeah. And you can somewhat see it on the fMRIs and that kind of stuff.
Sure.
Yeah. Because I've also spoken to one or two people, and they say, oh, well, we won't really believe it until the neuroscientists got all their pictures up on the wall and then we can see it. But they've done that, haven't they?
They've done it. Yeah, it's then they can find the literature and then they can believe it because it's all there. It's all been published.
You're going to know what to put in the search box, that's for sure. Okay.
Yeah, you can just do hypnosis fMRI and you'll see 30 studies.
All right. So we'll put that on the website. The skeptics, the St. Thomas, that you have to put your hand in the wound. Anyway, the doubting
Yeah.
Thomas. Yeah.
Well, and that's good. I think there needs to be literature and research, and people should be
Yours.
skeptical.
Yeah, no, we like it.
Absolutely.
Yeah, we
But
like the
the evidence
debate.
is there. Yeah.
Yeah, but
Yeah.
not to be unreasonably resistant becomes a bit silly, doesn't it? Okay, so yeah, so we've got to tell them where to look for the research if that's their thing that they want to look about. So the mechanism, so there are mechanisms in the brain where these changes are taking place, or is that something that you would buy into? Or is it too
Well,
complicated?
boy, that's a big question. The We do know that there's not a pain center, for example.
No.
We know that pain is an output of the brain and not an input. Pain is not something you sense, but something you create.
Okay,
The
yes.
brain creates pain in order to protect oneself, and
Yeah.
it creates pain when it experiences input and concludes that input means that damage is happening or is about to happen. Then it gives us pain. So to change our experience of pain, we need to change how the brain responds to input.
Right.
And a key piece of that is changing the meaning that we give to the sensory input. And that's happens in the frontal cortex.
Okay.
And so that's one of the places, a significant place where hypnosis operates. But we also can use hypnosis to tell the sensory cortex, you know what, just calm down a little bit. And you don't have to process that information as pain.
Okay.
So it's multiple mechanisms because the mechanisms that create pain are multiple.
Yeah.
It's a sensory, affective,
yeah.
cognitive, and many sections of the brain are involved.
Yeah.
That's probably why hypnosis is so effective, because all you have to do is interrupt any one of those and you get pain relief.
Right. Right. So thinking about acute pain versus persistent or chronic pain, we used to call it chronic. Do we call it persistent pain now? Has that got a slightly different? Oh, we don't matter. Doesn't matter.
Yeah, we still kind of call it chronic pain, but I also, like many clinicians, don't like it because chronic means, if you tell somebody you have chronic pain, it means you're going to have it forever. And that's not true.
Yes. Okay.
You don't have to have it forever.
But it's just a device we use to give it a name of some
Yeah,
sort.
it's shorthand.
Okay.
Yeah.
So would you normally incorporate other things like CBT and walking and getting out and around and mixing with friends and doing an art course? Are these all quite powerful things that you can add in when you're treating your pain patients? Yeah.
Yeah, not just add in, it's essential.
Right.
We don't just use hypnosis to decrease pain intensity.
No.
We use all of the strategies to help a person get their life back and to live a full, enriched life, even though some days they'll have pain and some days less pain.
Yes.
When they do that, and when especially the brain understands that these sensations are not a danger to me, it'll be, their pain levels will go down significantly.
Yes, the
But
threat.
it's not about eliminating pain. It's about getting your life back. So you must exercise, eat well, sleep well,
Yeah.
connect with people,
Yeah.
get control over your brain. Doing all those things, you'll be able to do more and hurt less.
Yes. Yes.
And so yes, all those things should be a part of the treatment. Absolutely.
But some people get on better with CBT than they do with other things. You know, there's a whole range of things that suit the personality of the patient. So you'd have a multidisciplinary team trying to work out what you do.
Yeah, it's best to have that. Yes. Yeah. And no, every patient responds to different things in different kinds of ways.
Yeah,
So
and then you can max out what they like best. Yeah.
Yep.
Yeah. Okay. All right then. So are some people unhypnotizable? I mean, in your experience, how often would you encounter that? That they just don't.
that it doesn't make sense to me, the idea of, we are all open to suggestions
Yes.
of others.
Yes.
Every one of us. And some of us are more open than others. But how open we are to suggestions depends on many factors, including biology, how much white matter you have, but also time of day, your relationship with a person.
Yeah.
If you decided at some level that the person is trustworthy and and what they say is true, then what they say will become absorbed by you much more easily. That's why rapport is so important in clinical relationships.
Yes.
It's also why it's critical that as clinicians, we have our clients' best interests at heart. It's all about them.
The healing intention.
So,
is it called the healing intention? I think it's referred to as that in.
Yeah, it's all about them. And so when we have that relationship, they're going to be more neuroplastic, more open to suggestions.
Yeah.
So this idea of someone is not hypnotizable, they are not open to suggestions, makes absolute no sense to me.
Don't believe in it.
I don't believe in that. I do think that people are more or less
there's a range.
Suggestible.
Yes.
Yeah.
So how many people would you say in your practice are extremely hypnotizable? How big a chunk do they occupy?
10% maybe.
Oh, right. It's quite a lot.
Yeah.
And they're easier. And
but they're easier in some ways, harder than others. They are more open to their own thoughts. And so if they have negative thoughts, they're going to be digging themselves into holes.
Oh,
They are more open to suggestions from those around them. So if they're in a work setting or in a relationship that's hard, they're going to be more vulnerable.
yes, yes.
So every patient has their own strengths and vulnerabilities, and what we do is we design a treatment that helps them, that
Yes.
matches what their strengths and vulnerabilities are, to teach them, how to protect themselves against their vulnerabilities and how to build on their strengths.
Okay.
So there's and I like working with every patient. It's not like, oh no, this patient's hard to work with. Good.
No, we love a challenge. And I suppose if somebody's
Yeah.
going through a terrible thing like a big complicated divorce or getting the sack from work, it's going to be a little bit more difficult to treat, or maybe not.
Yeah. Although when we have compassion, we can be a real useful to them. They'll need us more. And so that gives our work more meaning, maybe.
Yes, yes. Wow. So in your department, did everybody learn hypnotic techniques in terms of like the receptionist would know not to say, oh, it's going to be painful, that kind of stuff? Do you teach all your whole team? Have they all had some kind of training?
We don't, I'm in the Department of Rehabilitation Medicine. I'm not in anesthesiology. But I guess that's a good question. I embarrassingly, I haven't trained all of our residents in the use of hypnotic language. I suppose my excuse is that I'm just incredibly busy. So that'd be like one
Yeah,
more thing
I'm not going to bother with
that if
that.
I did that, I'd have to not do something else. But that's a good idea. I ought to do that.
Just get everybody on board. But I think they model, if
Yeah,
you're modeling, if you're leading the ship, you model something and people, if, it
exactly.
seems to work,
Yeah,
then they'll model themselves on you. I think that's natural human
yeah,
thing to do.
yeah.
So, yeah, that was the question. Oh, yeah. So some of your people who come in, so in the rehab department, you must have lots of veterans and war traumatized people with chronic pain. Is that something you come across?
Well, not so much in our department, but we staff the local Veterans Administration hospitals. So we have many veterans in our clinical trials.
Oh, yeah.
Many. Yeah.
And these are people with chronic pain or just a bit of everything?
People, well, a bit of everything, but people who are veterans have a higher incidence of chronic pain than those who are not veterans.
Yes, yes.
Women who are veterans have an even more incidence of
Oh,
chronic pain because
really?
they have to deal with not only being a veteran, but also being a woman in this setting that is toxic, can
Oh,
be toxic.
yes.
Um,
What you mean toxic from
so
their
yes,
male colleagues or toxic because they're bombs,
uh-huh.
everything?
Yeah, both.
Oh,
Yeah.
life's bad enough. Okay. So if you've got people with, they've had an emotional trauma, they've been in an explosion or a fire or something, and they're presenting with their chronic pain. I mean, I've had one or two. I went to talk to a pain clinic recently, and they said they'd be very reluctant to treat people who'd had trauma, getting migrants in the London area who are coming in, who've been in war zones and all this sort of thing, nearly drowning coming across the channel. Are you concerned about the trauma stuff? Would you get a psychologist or a psychiatrist to deal with that before you did the hypnosis for their pain? How would you?
Hypnosis is an incredibly effective treatment for trauma. So I would just dive right in.
Oh, all right. Okay. So do you have a particular approach for that? Perhaps it's in your book or somewhere.
Actually, no, I don't have a particular, I mean, I use a number of strategies, but with hypnosis, we have a fair number of
Yeah.
strategies,
Trauma.
having people learn how to get solid,
Yeah.
um, age progression, age regression, building resources around the stimulate things that stimulate the trauma.
Yeah.
Um, you know, Hypnosis is about creating automatic adaptive responses
Right.
using associative learning.
Okay.
And in the hypnotic state or more flexible state, that learning is easier to happen and it sticks more. And so we just link positive feelings of strength to the things that used to trigger these negative states and slowly build resources and capabilities. It's
Yes.
pretty straightforward. So I can't imagine saying, no, no, I'm not going to treat you. Well, that's like, why?
Well,
That's your job.
well, there is some anxiety about it. I suppose before people have done the hypnosis training, they would worry about, ab reactions and people having, bad experiences of it. Okay. So,
Yeah, yeah, yeah. Yeah.
but
We're therapists. We know how to deal with that
yeah,
reaction.
that's a doddle. So do you use EMDR? Do any of your colleagues know? Because that's supposed to be terribly good for PTSD and trauma, isn't it?
I think it's a type of hypnotic
Oh yeah,
intervention.
it comes out of hypnosis. Yeah,
Yeah,
using
yeah,
imagery and a funny thing about moving your finger. Okay,
yeah.
so
Well, don't pay attention.
yeah,
I mean,
doesn't make sense, but that doesn't mean anything really in this day and age, is it? You can sort of
well,
if it
yeah,
works.
I mean, there is some evidence to support it, and it makes sense that having a close relationship, doing a rhythmic experience makes your brain more flexible. So that's how I see it as
Yeah,
a hypnotic type intervention.
yeah, no, I mean, I think it does have some evidence, doesn't it? Okay, so we're getting a little bit more interest from our clinical colleagues. They're creeping in very slowly. I think partly because they're being told they can't use opiates anymore. No point in giving an injection into the facet joint in the back because that doesn't have an evidence base, no better than placebo. So they're beginning to be pretty desperate for what are they going to do? And as you say, they want to make a difference. They want to help their patient. They don't want to have failure. And they don't want the patient keep coming back either, because, that's always a bad thing. So I think there is some movement now, and we've got quite a few anaesthetists who deal with pain booking into our little training in the autumn. So we're hoping that one day hypnosis will be a completely routine thing, not just for specialist pain clinics, but that all clinicians can use
Yeah,
it. I think, also
yeah,
just teaching the simple language, not necessarily, because there's the two levels of it, isn't there? You can just do hypnotic techniques in the way you use your words. And you can also do formal trance inductions where a patient is there for a while and you give all the healing suggestions. But just not saying the
yeah,
wrong thing, like this is going to hurt and oh no, you look terrible, that kind of stuff. I mean, you can train
that's right.
your whole staff to tidy up their language. Okay, so
Yeah, yeah. Like anesthesiologists who tell their patients, "We're going to put you under now," or I'd like you to kiss your wife goodbye."
yeah,
Or when they come out of the surgery saying it's all over. I mean, you're very careful. You should be very careful with your language.
we got to work on those people. They don't know they're doing it. It's all so
That's right.
obvious.
It's inadvertent. Absolutely, it's
Yeah,
inadvertent.
yeah. But you don't even have to say I'm going to, when you're putting in a cannula or something, you can just say I'm just going to give you the local anesthetic and I'm going to give you some fluids now. You don't have to use references to
Yeah.
needles, injections, and all that kind of stuff. Brilliant. Well, that's been good. Have you got any other amazing things that you want to add to that? But that's been brilliant, and thank you so much.
You're very welcome.
It's,
You know, I guess if somebody's new to this, I would just say give it a go, learn some things, and I think you probably I expect will go, well, this is pretty cool. I have something I can offer my patients that brings
yeah,
them comfort.
yes,
That's why we're here. And as I said, it's shown efficacy. It has a wonderful side effect profile. So
yeah,
why not add it to your
yeah,
armamentum? And it's not that it shouldn't be the only thing you have, but it should be
no,
one of the things you have.
sure, of course, yes, absolutely. Brilliant. That's fantastic. Thank you, Mark. I shall disconnect now and we'll have it on
Okay,
have the recording. Thank you so much. Anyway, enjoy your next big trip and we'll talk again soon, I hope. That was fabulous.
okay.
You. Yeah,
Take
bye-bye
care,
now.
Maureen. Bye bye.